Good morning. So thinking about deterioration and the deteriorating patient is a massive area of healthcare. And whilst we've made great inroads in this topic area over recent years, we could do more. We could go further and we could be stronger in our attempts to bring the concept of the deteriorating patient to the general table of general healthcare and ensure we have the support and the quality improvement, funding and staffing necessary to deliver on the aims. It's a complex area. It's a very big area, touching on all sorts of elements of team working, collaboration, data and measurement, quality improvement, training, education, and personalized care. Doing the right thing by patients and not necessarily throwing everything at a patient, but actually meeting their needs and requirements as well. So this complex world is really well summed up in a very complex diagram, which was beautifully created at a recent conference. On the input of all the attendees. And this sort of grand mapping of how deterioration links across the entire care pathway is the subject of this talk. So in terms of what deterioration is, and many minds have been on this thinking about what deterioration represents, and the best, I guess, almost consensus definition we've achieved is that it is an unexpected acute worsening of physical health, appreciating that there is a mental health deterioration as well and other causes, that for the purposes of, I guess, physiological deterioration, that fits quite nicely. So every patient starts at a baseline, and then there is an insult of one form or another, and a slippery slope in those that have bad outcomes. This concept of deterioration, which either leads to sometimes an emergency admission, in very sad cases, death. The insult itself is variable and can be multiple different conditions, including disorders to do with endocrinology, infection, diabetes, vascular problems, trauma itself, or diseases of aging or cancer. A great number of things can be the trigger or the insult. And in recent times, as you all know, this has been very much in the realms of COVID. What we get time and again before the admission or death is a measurable worsening, usually of physiology. And that's the essence of this. What can we find early on in the course of an illness or a deterioration that might signal a bad outcome, that might give us a signal that something needs to happen? What can our system be better at preparing us for, to be aware of when a deterioration is about to occur and to intervene early? What are the points where escalation and response will make the biggest difference? It's also important to understand scale, something that we don't recognize well in the deterioration field. Because actually, to have a non-elective emergency admission, you have to have deteriorated in the home environment and traversed that collaborative pathway. And when you look at non-elective care, it actually comprises of more than 90% of total NHS bed days. And patients that die in hospital beds are deterioration linked in 98% of cases. Non-elective care itself is over half of admissions, but the lion's share of the bed days, nearly all the deaths, with a mortality rate that far outstrips that of elective care, and quite rightly. Optimizing its care is going to take a massive effort, both of national mobilization, potentially some reorganization of national structures, collaboration across national structures, and then system-wide leadership and support for frontline delivery of care. The bed days themselves are a compelling argument, and the deaths themselves, but it's more than that. It's thinking about what might be amenable, both reversible and preventable. And when we look at the trends of who comes in what age bands, and that's what this graph shows across England for the past year, we can see that although a large number of admissions are in younger patients, it's not them that die. Logically and sensibly, it's the older patients that die with higher mortality rates. So if a mortality rate ranging from 0.02% in the youngest age groups to over 12% in the oldest age groups. And this is a pattern that has not changed over the past 20 years. We have to accept that some patients will die, and we have to accept that sometimes the best thing to do is to consider the palliative routes of both non-admission sometimes, but admission with appropriate care. And this is an important concept within the world of deterioration and what we do to plan systems. And when studies have looked at conditions like sepsis to examine the chances of dying and who actually dies of true sepsis, and then what the comorbidities are like within that population, we soon find out that actually out of the ones that really die of sepsis, and this is a study from Wales, over 3/4 were at least moderately frail. So pretty impaired and probably towards the ends of their natural lives anyway, which lends weight to a lot of theory that actually sepsis and infection-related deaths tend to occur as a byproduct of the infection, not necessarily causatively due to infection. So severe comorbidities like end-stage heart failure, chronic obstructive pulmonary disease, or cancer can sometimes be the real cause of death, with the sepsis being the insult or the infection being the insult added to it. So it's really important within our deterioration pathways, we consider not only the cause, not only the early recognition, but also the appropriateness of treatment. And that's what wonderful initiatives like the Respect Tool and others do, to actually ask that question about personalized care. What is appropriate for this patient? What's in their best interests? When we look at thematic analyses of safety incidents leading to severe outcomes, either death or critical injury, we find that nearly all of the events that lead to preventable episodes are to do with deterioration, either due to, as Sir Liam Donaldson found, poorly managed deterioration, a failure to spot preventable deterioration, and deficient monitoring or checking. And when we do a root cause analysis of sentinel events, and this was done in the United States for all critical loss of life or limb events, they found that communication was number one nearly all of the years that it's been surveyed, which is interesting. How we speak to each other and communicate across the healthcare system is a critical element of patient safety, and indeed how we manage deterioration. The other environments, again, have absolutely everything to do with collaborative pathways, continuum of care, how patients are put in beds and which beds, how staff are trained, and how they are assessed. A good analogy is this reflex arc of a trigger being a deterioration episode, and then how the system reacts to that deterioration in a reflex arc to enable a response. And this is a good analogy for how we think about deteriorating patient symptoms and syndromes. Helen Hogan and team did a really good study called PRISM that actually looked at hospital-wide mortality rates and what elements of that population were truly reversible. And what they found was that the actual avoidable stroke preventable rate was actually lower than we expected, at around the 3.6% mark. Now, that's not to say we have not got room for improvement, because one avoidable death per week in each hospital across England is amenable. It's something we should be doing something about. And it's sobering to realize just how many avoidable deaths that leads to across the country per week, per year. These had a common theme of failure to spot severity or optimize patients, inappropriate delays sometimes, and inadequate monitoring. And sometimes we got the diagnosis wrong. So nearly all of these were deterioration-related factors. We've had consistent and repetitive report findings for many years, suggesting that patients don't suddenly deteriorate, but we suddenly notice. We found over the years that intensive care admissions could have been managed better. There's prolonged physiological instability in patients that go on to die. There's sometimes inadequate response. There's a suspicion that there's avoidability of these episodes, both in terms of deaths and intensive care admissions. And generally, there have been themes around poor communication and clear, clarity on what review criteria should be and when escalation should be triggered. These are all lessons, and I know others on this talk are going to talk about the peer approach. I'd like to focus on planning within that, because planning is a huge element of how we can make the system better, not only in terms of treatment escalation planning, the systems themselves, but e-systems as we go digital, how staff are prepared, how staff are rostered, and how many we have on at each shift, monitoring the system for safety proactively. And then the incentives across the system that enhance good behavior and improve the way deteriorating patients are picked up. These are all opportunities for improvement. Fundamentally, there are a number of different versions around the country, including the recognize and rescue or recognize and response versions of this. The words don't matter so much, but consideration of all the different factors that are really critical to getting this response and recognition right are important. John Welsh shared this slide, and I think it's a really powerful slide. The elephant in the room being obviously nurse staffing levels and ward staffing levels and staffing levels of junior doctors and allied healthcare professionals. Because if we haven't got enough bodies on the ground, then we can't always deliver a safe service. And this study from HSDR really elegantly proved that levels of temporary staffing and inadequate nurse staffing and healthcare assistant staffing was absolutely critically linked to outcomes. Something we can't hide under a rock about, but we need to acknowledge, at least in the first instance, and then think about strategies that we can put in place to actually overcome this. The acuity of our patients on the wards has never been greater, and the complexity of what our staff deal with day to day has never been greater, together with all comorbidities and the degree of what we can offer them in terms of treatment. These are not small concepts, and our fantastic staff have to put up with this every day. There is news on the horizon of the National Maternity Early Warning Score, which is welcome news as we seek to standardise how we respond to deteriorating patients who are pregnant across all hospitals. A plan is forming, and we hope in due course we will have a standardised national version. The same is being planned for paediatric early warning scores, termed SPOT. And we have advanced planning in terms of testing underway in sites, and this has all gone out to final review and consultation in due course. And again, standardising the language of sickness for both those who are pregnant and those who are children would be welcome next steps as we improve, or we seek to improve, deterioration management in different client groups. There are lessons from news to share with maternity and paediatrics. A journey that has started many years ago was assisted by data in terms of mortality, but also scale, and patient safety alerts and mandates from the centres sometimes, and incorporation with the national standard contract. And what that led to in terms of the uptake in all acute trusts and ambulance services around the country, something that really helps the pathway. We are not islands. Hospitals are not on their own. They are linked with their communities, and communities are joined with their hospitals by the interface and their terrific ambulance services. We know from the evidence that when you do implement a standardized language, it can have dramatic impact both on mortality rates, but also cardiac arrest rates. And this is where we hope to have the largest impact of all across all our patient groups over the years to come. News is evolving. Two recent changes in 2021 were in response to what healthcare professionals were telling us, and we had e-forums and very open debates to discover that actually there was a problem. There was no point just knowing about your news score and recording it and doing monitoring. But what was really important was the standardization of what that response was like. What would be our national standard? So the Royal College did some really quick work to develop additional implementation guidance to lead to a news of 5 and 7 to be responded to and with a review by a clinician within 60 and 30 minutes respectively. And that was really important because the study showed there was huge variability, and the more we standardize the response and the language, the better our systems are going to be. The other important key change in 2021 was of a change in the news response in response to rising oxygen requirement. So junior doctors and frontline clinicians noted that actually as patients got sicker with COVID, they already came in on oxygen. They wouldn't score any more for having very large quantities of oxygen. So it was important for clinicians to be reminded that escalating oxygen requirement was another real red flag in picking up deteriorating patients with COVID, and one that wouldn't necessarily add points to the news score. These are really important elements, as is recognition that actually, although News 2 is great and the evidence shows that it does predict mortality within COVID, it's not absolute, and clinical judgment is paramount, as it is across all conditions. A number of other initiatives have begun too, including RAPID, the response to acute physiological derangement in the emergency department. And we hope to launch this later on this year, and this idea of looking out for critical illness and ensuring again we have linked urgent clinical assessment and response within 60 and 30 minutes for the same core standards as in the Royal College of Physicians guidance. Because we know from large-scale studies that 5 and 7 induces a very much higher mortality rate at 5 days, 30 days, and over an extended length of time. And that using news of referrals tends to improve outcomes. So the opportunity is there for this common language to really grow some wings and actually be held to account in terms of how quickly we respond to deteriorating patients across the whole of healthcare, including the community in due course. Because the evidence is there now, as these studies show, that if we record the news score and transmit it at the referral point, it does predict outcomes, both at 5 days, 30 days, and all length of stays. Again, we have jumps and bumps at the news 5 and 7 level. And again, there is some sort of protective element about using a common language at referral points. So this is exciting news and stuff now in a post or peri-COVID world we need to build upon. Because if we can get this right and actually improve the communication across the care pathway, we can start setting urgency, plan where we see them, prepare for them, and place patients in a safe and appropriate environment to ensure that the pathway is joined up all the way from home when a patient first becomes ill to how they are assessed in the community, how they are transferred to hospital, and then how they are passed along in the hospital in their admission journey. What can really help us in this journey includes a standardised community referral form, and work was being undertaken pre-COVID on all of this. And we hope to pick up the baton again now in this peri-COVID world. It's easy for us to think that nothing is a problem with deterioration. And if we do monthly spot audits, sometimes it doesn't give us the right answer. Sometimes it takes a warts and all audit where you swoop in on every single patient in the entire hospital, actually see what happens to those that deteriorate, to look at what sort of documentation is recorded. And in this particular hospital, we found that nearly half of patients, there was no documentation of anyone being called with the new news of 7. So critically ill and injured patients. So if we're really serious about improving deterioration, the first port of call is improving the reliability of recording. And news of 7 patients, 50% of them die within 30 days. We're talking about a very sick crowd of patients. So ward deterioration sequence was proposed 2 years ago. COVID got in the way of us implementing it. And we hope, fingers crossed, from April, we might be able to revisit this. So these sequences are all about trying to incentivize good practice and good behavior. And this sequence is all about getting people using deterioration patient proformas on patients that significantly deteriorate. We're going to measure it in the intensive care level. So if you've ended up in intensive care, then you have to have had one of these forms, is the basic premise. And this is a really good example from Nottingham, where it takes you through the assessment, the response, and the next plan and actions. Really important stuff. Because if we can nail reliable recognition and response, then that's half the battle here. And if we can document it, then we're on the road to improving our outcomes, recognizing that this can only really be delivered with enough staff. We must get that leadership sorted both nationally, but also in our organizations. Silos must collaborate. No person isn't an island, or no specialty is an island. And we need to incentivize good practice, both in terms of dividends, in terms of reduced admissions and length of stay and mortality rates and improved recovery for patients, but also cognizant of what people really say when they get sick. And that doesn't just mean medicalized symptoms, but actually a sense of worry and concern from patients as well. Using our outreach colleagues is really important in a hospital environment, to think about how we prepare the workforce and plan systems to better pick up deterioration. Because at the end of the day, outcomes are predictable from when the patient first feels ill, from when that first set of observations is taken. And that's the point. If we join the pathway up, we're going to save more lives. And though COVID has taken a massive toll on NHS staff everywhere, we need to be really careful about what we put in place. It must be evidenced. It must make a difference. And it must absolutely benefit staff and patients together. So thank you very much for listening.